Hello, and welcome to the third and final installment of the American Foundation for Suicide Prevention's Health Equity Summit. I am Vic Armstrong, Vice President for Health Equity and Engagement with AFSP, and I will be your host for today's webinar. For those who are able to join us for our first two webinars of this three-part series, thank you and welcome back. For those who were unable to join for either of our first two webinars, fear not. You can access those recordings on our website, afsp.org/theupright. I will drop that web address in the chat. Also, there will be a brief survey at the end of today's webinar. When prompted, please fill out the survey to share your thoughts about this webinar. Your feedback is very important to us, and thank you in advance for your participation in providing that feedback. For anyone who is unfamiliar with the American Foundation for Suicide Prevention, or AFSP, we are the nation's largest suicide prevention organization with 73 chapters across the United States. We have chapters in all 50 states, plus Washington, D.C. and Puerto Rico. We're also the nation's largest private funder of suicide prevention research. As a leader in the suicide prevention space, AFSP recognizes the importance of access to suicide prevention resources, particularly for populations and communities who have historically lacked such vital access. We also believe that communities know best what resources work for them, and that without including the voices representing those communities, resources lack the authenticity to address the intersectionality of those communities. I, for example, am a senior leader with AFSP. I'm also a social worker, a husband, and a father to 3 Black boys. I'm a mental health advocate, and I'm the son of a preacher born and raised in rural North Carolina, now residing in Charlotte, North Carolina. I share all of this because I am the sum of all of these things. All of these impact my access to resources and my perception of how suicide impacts my community. With these things in mind, AFSP has embarked on a health equity initiative in which we will use our resources, relationships, and position to catalyze both local and national efforts to address inequities. To address these challenges, AFSP recently launched The Upright, a collection of AFSP's resources, including research, programs, and policy that aims to advance health equity in suicide prevention. The Upright is a part of AFSP's commitment to support communities with disproportionate impacts related to suicide. And we believe that we can address the issue of access by supporting the creation of more mental health resources in marginalized communities, underserved zip codes, including rural communities, and communities disproportionately impacted by suicide, such as construction workers or veterans. We can create more community-based resources that provide access to upstream, culturally relevant treatment, which will allow us to reach individuals before they reach the point of suicidality. Creating The Upright stems from research that tells us that developing suicide prevention strategies for underrepresented individuals needs to be anchored with the understanding that communities have unique lived experiences and need to see their experiences and identities reflected in resources. The Upright is about connecting communities and driving change in the suicide prevention field. Together, as advocates, influencers, policymakers, legislators, and those with lived experience, we can move the needle on health equity in suicide prevention by reframing and identifying health equity as a population health approach, and by both encouraging and facilitating support for communities to build their suicide prevention programs with sustainability and transferability. So again, welcome to AFSP's Health Equity Summit. And let's begin. It is my honor to introduce the moderator of today's panel, which will explore how we engage communities in the work of suicide prevention. Our moderator, Dr. Kent Key, is an associate chair for the Charles Stewart Mott Department of Public Health in the College of Human Medicine at Michigan State University. Dr. Key.
Thank you, Victor. And we're so excited to be here and to have this opportunity to hear from these wonderful panelists as they share how they are centering health equity in their work. Our panelists will be Dr. Mary Swick, Associate Director, Senior Scientist, and Licensed Psychologist at the Center for Indigenous Health, Johns Hopkins Bloomberg School of Public Health. In addition, we will hear from Dr. Alicia Barnes. She is an Associate Professor in the Department of Psychiatry and Pediatrics. And we will also then hear from Dr. Justin Jen. He is the Vice Chair of Ambulatory Services and Vice Chair of Health Justice in the Department of Psychiatry from Cornell Medicine and New York Presbyterian University. Dr. Swick?
Thank you so much, Dr. Key. Hello, my name is Mary Swick, and I work at the Johns Hopkins Center for Indigenous Health. I've worked in Indigenous suicide prevention for about 20 years now. I come to this work as an ally, a partner, and a collaborator. We cannot reduce health inequities in suicide without forming partnerships and without using a community-based participatory approach to engage high-risk populations. We will continue to design approaches that are ultimately unsuccessful until we invest time and understand that this process brings rigor and meaning to the work and to the lives we are hoping to save. Indigenous peoples hold the knowledge and cultural assets needed to prevent suicide. First, most Indigenous communities are already engaging in suicide prevention. Second, we cannot assume that what we know personally or professionally about suicide prevention will apply to any community that we are working with. And it's important to note that there are many differences within and between Indigenous communities. Native communities have different age trends than the general population, and the types of mental health concerns that impact their suicide risk will also differ. Furthermore, there are distinct psychosocial stressors due to racism, discrimination, community violence, adverse childhood experiences, and different access to mental health resources. If we are wanting to come to this work as allies, it is best to make connections, build trust and relationships, and wait to be invited to help. One of the strengths that our Indigenous communities have is the wisdom of their elders. One of our local community teams could not have built out their suicide prevention work without the support of their elders and the Elders Advisory Board. They guide the direction of the work, can help to break cultural taboos, like making it more acceptable to talk about suicide, and help frontline workers with burnout through prayer, ceremony, and other means. Some of the most important things and some of my most cherished moments have been with our elders, in particular in the Apache community. They have taught me, as a partner and an ally, the importance of listening, talking less and using our ears more, being present in the community. This might mean participating in community events, ceremonies, in addition to storytelling and narratives, and how important it is and how they shape our ideas about suicide and how we can prevent it. Our elders are critical to engaging many Native communities in suicide prevention. Another strength that our Indigenous communities bring is connection to the earth. To engage with Native communities in suicide prevention involves recognizing the importance of land to their identity, their cultural teachings and practices. In addition, as potential partners and allies, it's really important to participate in activities around Native lifeways. Suicide prevention can involve field trips for youth to sacred sites on the reservation and equine therapy. The work and relationship building is not always taking place in an office or a building or over Zoom. Providing and raising awareness about land acknowledgements can also be very important as an ally and partner in Indigenous suicide prevention. One thing that we can all do today on this Zoom meeting or after is to look up on which Native land you currently reside. Third, the teams that I have worked with have studied risk and protective factors to inform strengths-based approaches that have shown the importance of culture as medicine. We have seen protective factors such as school attendance and attachment, strength of your ethnic identity, how much you value your Native identity, how much you value American Indian traditions and practices, how much you desire as a young person to continue those practices as an adult, in addition to positive social relationships and having caring adults who are close to you, are all strengths that we can work towards together. Engaging with communities and in suicide prevention may mean things like language revitalization, developing cultural-based curriculums, and increasing access to ceremonies. Fourth, a holistic approach to suicide is the only way to engage communities and reduce suicide death rates. Indigenous communities have been leaders, and many other communities as well, in what many of us call a public health approach to suicide prevention. And we just need to listen to our Indigenous allies and other communities as they are on the forefront of this. This approach also understands that we won't reduce these health inequities in suicide until we deal with its intersectionality. Suicide is complex and intersects with substance use and other forms of violence. We cannot continue to treat these issues separately. We need to think about and address the root causes of these disparities. Finally, in addition to our relationships as collaborators, allies, and partners, are the importance of the frontline workers and helpers in these communities. Here you see a picture of one such amazing team called Celebrating Life. This team has developed and studied several evidence-based interventions for suicide prevention. But no matter the program, in the end, it comes down to the impact that caring community members and we as allies can make. We should not underestimate them, even though they may not be in traditional professional roles. In partnering with communities, we should support and build the community members up. And no, there are times when we just need to get out of their way. We have shown that regular follow-up and case management by caring community members can decrease the likelihood of future suicide attempt and death. Community health workers can and are saving lives. Thank you.
Hello, thank you for having me on this panel. I'm Alicia Barnes. I'm the Chief of Psychiatry at Le Bonheur Children's Hospital in Memphis, Tennessee, and the Urban Child Institute Endowed Chair of Excellence in Child and Adolescent Psychiatry at the University of Tennessee Health Science Center. I'm grateful to be a part of this panel as well as the launch of this important initiative to connect resources to the community. Today, I want to talk about ways in which we can center achieving improved outcomes with youth and children's mental health. We currently are in a children's mental health crisis, noticing that in the last decade, the trend going in the opposite direction, where there's an increase in youth between the ages of 10 to 24 having completed suicide. And so in our field, we're looking at different ways to engage the community to send this trend in the opposite direction. So I'm happy to talk about some of the work that we're doing here in Memphis, Tennessee, to affect that, and some of the work that's being done nationally with a system of care approach to address those needs. With my background as a healthcare practitioner, as a healthcare provider, and as a public health practitioner, one of the benefits of taking a public health approach or a population approach to mental health allows us to engage early on with needs in the community, as well as look more upstream to what's going on and who's throwing the baby down the river that usually appears in our clinic with increased suicidal thoughts or depression or anxiety. So one of the things that we've looked at is academic and community partnerships in order to build those connections that are sustainable in our community and serve as a resource to schools in our region, as well as areas that otherwise have fewer resources. So by centering academic and community partnerships, we take a system of care approach, which was originally designed by a child and adolescent psychiatrist to address children with severe emotional disturbance. And it's an approach that has strategic plans in order to address the need of complex issues, oftentimes children interfacing with multiple sectors within our community, whether it be juvenile justice, school-based systems, the healthcare system, which I'm a part of, or community-based systems or after-school programs, and helping them in which to navigate those difficult systems to have an outcome that is agreed upon by the family as well as the child. Our current children's health crisis, we understand, has been declared by the Children's Hospitals Association, as well as the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics. That one of the challenges particularly is the amount of healthcare professionals that are available. So this drives us to use an approach that centers community and peer supports, which was previously mentioned as a key factor and resource in solving these solutions as we move forward. Currently, I'm involved in a project called Creating Atmospheres of Resilience in Education Systems, where we've partnered with schools in under-resourced areas and working with teachers and parents in the system of care approach for them to identify one of the key factors is it's family driven and youth guided. So what are the important aspects that they're seeing in their community, in their schools, and as needs to reduce the burden of mental health and actually promote mental well-being for these youth and families. We know a lot of the areas are challenged by public safety and traumatic events. So a lot of our interventions have been geared towards teaching language about identifying adverse childhood experiences, as well as promoting positive childhood experiences and activities that could help prevent negative outcomes for our youth and their families. But the key part, again, is that this is driven by families and guided by youth. This is a key tenet in the system of care approach. The other key tenet is that it's community-based. This includes faith-based organizations, nonprofit organizations, after-school programs, and really building a net and community that serves the populations that and where they live and operate on a daily basis. So, and key part of working with families and parents and caregivers is making sure that they are resourced and supported and navigating complex systems when challenges arrive. And then moving upstream to also have that engagement and building solutions before challenges arrive. So in taking that population approach. And the other key aspect before that is really useful is that it's culturally and linguistically centered, so that we're making sure that we're approaching these solutions in a manner that best serves the population and not trying to transfer one solution that worked for one community across, sometimes across zip codes. They may not be as effective. So thinking more wide scale about developing strategic plans to partner with schools, with government agencies, with nonprofits, faith-based organizations, and moving outside of our clinical practice has been one way in which this initiative has taken form for me. So thank you.
Thank you so much, Dr. Swick and Dr. Barnes, for your remarks. I've already learned a lot today. It's a real honor to be here. And first, let me also say thank you so much to the American Foundation for Suicide Prevention, especially Vic Armstrong, Christine Moutier, for hosting this important conversation and keeping health equity front and center as it should be. So as Dr. Key mentioned, in my day job, I'm the Vice Chair of Ambulatory Services and Vice Chair of Health Justice at Weill Cornell Medicine and the New York Presbyterian Hospital system in New York City. And so what that means is I'm thinking all day long about how to increase access to insurance-based mental health care in the New York City region. So in many ways, I think of my work as applying a public health lens to mental health. How do we determine or create in an environment of constrained resources a system that helps patients and their families get access to the right care at the right time? But in my free time, I'm really passionate about cross-cultural psychiatry and with a particular focus on Asian American youth mental health. And really, a lot of what I'm going to say is echoing what the prior two speakers have already shared. The dominant Western European model of mental health care in the United States does not necessarily translate well to other cultures, which have their own ways of understanding and addressing experiences of distress and suffering. The unique cultural and structural risk factors faced by the Asian American community are sadly reflected in the statistics. For example, our youth and elders have among the highest rates of attempted and completed suicides in this country, yet we are among the least likely to seek mental health care. We're about 2 to 3 times less likely to seek mental health treatment compared to the general US population, and this has been replicated in almost every study that's examined this. So I want to share some personal experiences. I learned a lot of these lessons firsthand actually during my medical and psychiatric residency. I did my psychiatry training at Massachusetts General Hospital in Boston, and I had the wonderful opportunity and privilege to rotate through several community health sites, which serve primarily immigrant and refugee populations from Cambodia, China, and Vietnam. And even that early in my training, it quickly became very clear to me that the tools of Western psychiatry that I was training in were largely inadequate, or at least very poorly adapted for serving those communities. So for example, at South Cove Community Health Center in Boston's Chinatown, frequently patients would be referred by their primary care providers to us in behavioral health to treat symptoms of depression. And they would show up only to never return after their first appointment. For many of these community members, psychotherapy was simply out of the question due to concerns that they had about sharing personal information that was potentially shameful or stigmatizing with people who are essentially strangers in the medical establishment, such as myself. There was also a huge stigma against taking medications, particularly medications that might be long-term or even addictive. And except in the most extreme cases, such as schizophrenia, the disease model of mental illness simply didn't translate at all. Instead, many of the patients had a belief that these were interpersonal problems or even defects of character that could be overcome by thinking less or just working harder. On the other hand, I saw powerful examples of culture as a strength and protective factor. For example, never forget the Chinese parents who would faithfully attend appointments with me, even without their child, who was actually the person struggling with symptoms of schizophrenia and could not leave the house. Or the visits by our clinical team to the Buddhist temple in Revere, Massachusetts, where individuals from the Cambodian community who were in treatment for mental health conditions such as PTSD, post-traumatic stress disorder, anxiety, and depression, were really finding meaningful opportunities to re-engage and reintegrate into the community and rehabilitate in a culturally appropriate way. So these were very, very powerful experiences during my training. Also, I have to say that in my journey, I recognized that this work is also deeply personal. I am the child of immigrants from Taiwan who moved to the US in 1973 to Enid, Oklahoma, in search of greater opportunities for their 2 children who had not yet been born. In many ways, their story exemplifies the American dream. Both of my parents worked very hard in so-called blue-collar jobs, waiting tables, cleaning hotels, as they put themselves through school, and eventually were able to provide an environment with the resources for my brother and myself to pursue stable professional careers. However, similar to many other immigrant families, behind these outward-facing successes were many hidden emotional struggles, both within my immediate family and among our relatives, both in the United States and in Taiwan. Immigrants face extraordinary stresses, pressures, and traumatic experiences, even if they are not recognized or labeled as such at that time. Looking back now, I can see countless examples of how a lack of skills related to understanding or managing feelings and communication greatly impacted relationships in my family, as well as both mental and physical health. I can actually say that I'm grateful for the combination of events, including some painful ones, that led me to become so acutely aware of the important role of culture in psychiatry. And I apply these lessons all the time in my day job as we try to bring in different questions to further complicate but also enrich the conversation. Which communities are we reaching? Which are we not reaching with our existing service models? How do we train our workforce in cultural humility, which includes an awareness of the foundational role of culture in how people understand and label their experiences? Which strategies can help diversify our workforce to better reflect the populations we hope to serve? What can our already under-resourced systems do to address the many structural barriers that prevent those at greatest risk from obtaining needed care? How can lessons learned from one underserved or vulnerable population, such as Asian Americans, be applied to better understand other populations? Which factors are generalizable and which are community specific? And I think also importantly, how do we shift our approach from one that focuses on pathology to one that also understands empowerment and acknowledges and actually seeks to enhance the inherent strengths of the communities that we wish to serve? Mental health concerns never occur in isolation. They must be considered within broader contexts and ecologies of families, cultures, and societal forces. So I'll end these remarks by giving a shout out to an incredible community-based organization that I've had the privilege of working with to continue to address the unique challenges faced by Asian American youth and their families. UCA WAVES, which stands for United Chinese Americans, Wellness, Advocacy, Voices, Education, and Support. Sorry, that was probably pretty fast. UCA WAVES. This is a nonprofit that was created and run by an incredible person named Lily Chen, no relation. Lily is a Chinese immigrant mother of 5 kids and a nurse educator living in North Carolina, who's really made it her life's work and mission to address mental health stigma and high rates of suicide in the Asian American youth community. So whenever I think personally about how the solution for healing our communities must come from within the community itself, Lily is the first person I think of. And actually, Vic, you were there at our Youth Mental Health Conference in North Carolina just a couple months ago as a keynote speaker, so you've seen them in action. It's really powerful. Mental health and suicide are extraordinarily complex issues that require a multi-sector approach, as Dr. Swick said. We have to bring together community and families, academics and researchers, clinicians, educators, but also funders, payers, and policymakers. And UCA WAVES is taking on that challenge, at least within one community, in a culturally informed and community-driven way. So thanks again for inviting me to join this panel. I'm very happy to answer any questions.
So I would like to thank all of you for sharing these wonderful stories of how you are centering equity in your work. And question for you, Dr. Swick. So as you were talking about your work in Indigenous communities and the need to, uplift knowledge and cultural assets, share with us how you were able to build trust with your population, because as an institutional partner, we know that it's important to build trust with the communities that we're trying to serve. Can you share with us kind of what that trust building experience was like with you?
Yes, I am definitely happy to share about that. It's quite a process, and I want to say it's like a lifelong process, right? Because you establish that initial trust, but just like any relationship with a community, it evolves and grows and has different strengths and challenges over time. So I want to sort of set that up first. But for the initial trust, I think, one thing that helped me is I was affiliated with the Center for Indigenous Health, which already had researchers and individuals working with the tribe that I was going to start working with. So I had someone who kind of served as a bridge between myself as a new ally to this community and the community itself. So kind of I was invited in multiple ways. So I didn't just kind of go to the community and just say, I'm here to help. They had a role and they knew I was coming in to fill it. And I had some folks who kind of helped me with that transition. So that was one thing. I was kind of like introduced to the community by someone who was already trusted. So that really helped. I think, second is I'm primarily a researcher, and a lot of our research grants, so maybe if there's funders listening, they can listen to this part, is, we had to spend a lot of time in the beginning being out in the community. And that's what I really did. I went around, I learned, I went to different sacred sites on the reservation. I participated in cooking with the elders. Really just tried to be present and say, what can I do that is helpful to you? Instead of going in and saying, I want to do X, Y, and Z study, or I think this is the best solution for suicide prevention. I tried to really go in and kind of listen and even if they asked me to help on something that wasn't really what I was, supposed to be there helping with, if I could help them with it, I did. And so I think that really helped to build trust. And I think being humble, I could probably go on forever, but I'll share this last piece. I think being humble has really helped me because I think it made it clear in my presentation, I'm not Indigenous myself. So I'm coming to this work trying to be the best ally that I can. And we do make mistakes. And even if we are sometimes from, we could be Indigenous but from a different Indigenous community, for example, right? And so I think just being willing to admit when you make mistakes and learn and be genuine really has gone far in the community, and really just trying to uplift those local folks that I showed in that picture and having great relationships with them. So thank you for that question, Dr. Key. It's really important.
Thank you so much. And Dr. Barnes, you mentioned something that is very important as we think about prevention and kind of why we do the work we do. And you really uplifted the need for looking more upstream and utilizing more upstream approaches. Can you share with us some of the methods that you utilized as you were kind of bringing together the various systems that you were navigating to really support and advance upstream approaches in your work?
Yeah, thank you for that question. I think similarly, being a part of the community and really learning the work that's being done is a key first step in moving upstream. In terms of understanding what the strengths are initially, they're different, and it can vary by zip code. Some zip codes are very much old communities that have been there generations, and there is a cohesiveness that's very that really drives that community. But in some other cases, there's transient communities where families have moved from different zip codes to make up a new area. And sometimes that comes with its own challenges. So there may be some community building that needs to be a part of the process and goal setting. So really being a part of learning where the history of a place, as mentioned previously, is a key part of that in moving upstream. And also the generations within one household, you can find that there may be intergenerational trauma that exists. And so this is a family that for the first time wants to approach, or is not, as a lot of the youth are very interested in mental health. A lot of families, I find parents aren't in that same place, or caregivers aren't in that same place. And so being able to move upstream also means to talk across generations and engage families and the needs at that time. So it can take different forms in many ways, but I'll echo that one of the key parts of that is having humility to learn what are the driving factors, and really centering around the outcome that's defined by that family and young person.
Awesome. Thank you, Dr. Barnes. And Dr. Shin, you really, as you talked about kind of Western psychology and kind of the inadequacies that it has, especially when it's trying to be generalized across other cultures. And then you talked about stigma and the role that stigma plays. And so what measures have you utilized to address stigma as you engage in your work with the various populations that you serve, even just under the Asian American umbrella, right?
That's a very complex question, actually a really important one, because actually some of my early research focused on trying to measure stigma in this population and seeing the impacts if you could actually link that to outcomes in depression. These are, I would say, imprecise constructs. It's not like you can take, a measurement of stigma, but we ask questions like, how would you talk about this to someone in your community? Would you want to hide it? And you can give someone a score. And what we found was that among Chinese immigrants with higher levels of stigma about depression, it took them, they might get better, but they got better less quickly than immigrants who had less stigma. So you're getting at something core here, which is around cultural beliefs and how they may impact on illness course. And can we address it? There actually have been a lot of psychologists and researchers who've tried to do stigma interventions. Unsurprisingly, a lot of them focus on education. Can you just tell people? And I can tell you, I don't think that really works very well. I couldn't agree more with Dr. Barnes. When you, in the work that I do as well, the youth are very eager to have these conversations often. And then the parents, and I'm not a parent myself, and I have a lot of empathy for parents. I think there's maybe a fear or reluctance of engaging in conversation about mental health, a worry that it opens the door to kind of a permissive style of parenting that's at odds with whatever parenting they're trying to do. So I get that, I don't want to fully judge it, but that's a stubborn issue. As much as the younger generation might be willing to talk about it, if they continue to get messages at home that's like, this you're being weak, or you shouldn't, think about it too much, it's gonna be hard to overcome. So in my work, again, this comes back to the community. I think if an academic such as myself comes out and gives a talk about depression or suicide awareness, the room might be a quarter full of parents. And those are going to be the parents who already are kind of, somewhat open to that. So you have to reframe the conversation. At least I think that's been my experience. In the Asian American community, sometimes we've given talks about, let's say, the importance of emotional wellness for long-term success. And then suddenly the room is full and there's a line out the door, right? And a lot also storytelling, as Dr. Swick mentioned. Sometimes it can be too overwhelming and frightening to talk about these issues about yourself or your family. But in displacement, if you can hear about someone else, and that's where we find filmmaking and storytelling. Vic was at that conference I mentioned, and they premiered a documentary called Silent War, Asian American Reckonings with Mental Health. And I think one of the most powerful stories in there is about, it's a young father who, it's disclosed had bipolar disorder and alcohol use disorder and completed suicide tragically. And the family was still telling the family in China that he was alive after he had already passed. That was how strong the stigma was. So those types of examples, and then seeing the actual impact of such a horrible tragedy on the family, which usually because of stigma gets swept under the rug, that family kind of disappears from the community. But that just perpetuates the stigma. There's something wrong with that family. You don't talk about them, versus to have those stories come into the light. I think that's the way to combat stigma and shame, is disclosure and vulnerability, and that the whole community has to help heal, not just like send that family to treatment, right? It's sort of, what is their place within their society? So, it's not as simple as we'll create a pill for stigma, right? This is a complex, multifactorial approach.
Thank you each for your responses. And I have one final question, and I'm going to ask each of you to take 1 minute just to give a response to. And the question is, as we think about up and coming practitioners and researchers and advocates looking into the field of suicide prevention and mental health, what would you say would be the greatest lessons that you have learned that you would like to give to that upcoming generation? Dr. Swoots?
Wow, Dr. Key, what a big but important question. I'm excited to hear what the other panelists say here. But I think I'm going to end up kind of echoing a theme that I think all three of us have talked a little bit about. And I think it's that we need to think outside the box with kind of what our prevention interventions look like, right? It's not always going to be kind of one-on-one therapy with someone who's a licensed psychologist in an office, right? Doing, cognitive behavior therapy, even though we know there's some evidence for that, right? But it's not getting everyone, right? It's still not like 100% effective. So I think I would encourage young people, and I think they're really great at doing this, the up-and-coming professionals, to really get creative with the kinds of interventions we're doing. They can be involving nature. They could be, involving art. They could be upstream, strengths-based. And I would just love to see what they come up with.
Thank you so much. Dr. Barnes?
Thank you for that question. I think this was really great topic and final note to end on. In terms of centering the community and, as was mentioned earlier, centering the wisdom of the community as a key part of that. One of the things in a system of care approach is having peer support specialists or a family support specialist being a part of the team. I think these are complex challenges, and it can't be boiled down to a pill. It can't be boiled down to one solution or one pathway. I think we're going to have to think about ways to come together as across sectors and across disciplines in order to solve these issues, and particularly centering the communities that are at the community voice and the community wisdom that already exists as a part of that. I think that's one of the things I really hope for the next generation, that we think more heavily about. As we know, population health or public health hasn't been as funded historically as maybe downstream healthcare interventions. But I think moving forward, helps us to really center that approach and think about the greater good. I love that emotional wellness for long-term achievement as a goal and an outcome. It's hard to quantify what we prevented. And so I know that's one of the challenges in funding this work, because you can't say, well, I've prevented this amount, but we'll see it in epidemiology with the greater outcomes and wellness in our society. So I think seeing more people take that approach and as they enter into the field will get us closer to our outcomes we're seeking to achieve.
Thank you, Dr. Barnes. And Dr. Chen?
The challenge of going last, and maybe also the privilege, is that everyone already said a lot of what I would have said. I totally agree with the prior two. What can I add? One thing I would say is keep going. This is a great time to be doing mental health work. There's been, at least in my experience, a real shift, a seismic shift since COVID. I think people are taking mental health seriously in a way that, even 10, 15 years ago, it was quite stigmatized to talk about, or even to reveal that one is a psychiatrist, right? And I think a lot of that has shifted. So this is great, and we need your voices and your energy and your creativity to solve these complex challenges. The other thing I would say is, as everyone else has mentioned, mental health is complex. And what I mean by that is, we don't just talk about physical health, right? As though that were one thing. Physical health is wellness. It's like being able to work out and walk around and, have activities of daily living, but it also spans into illness and, cancer and disease. And the same with mental health. I think as we continue on, we're going to have to think more critically about these terms. And as everyone is saying, we currently think of mental health and mental illness, and then we have, it's the proverbial nail in the hammer. We have two tools, which are meds and therapy. And as everyone else is saying, I think we can be a little bit more nuanced about that and think about the many ways that what I would call sort of mental health and wellness, that's really not the domain of the healthcare system. And it's not the right treatment for it. We don't want everyone in individual meds or therapy treatment, right? That's not the goal. And none of us who are clinicians on the screen want that either. It's weird to hear us say that, but yeah, we don't want you to show up. Like, save us for people who are really ill. And then that's where the rest of society comes in. When we think about our country invests so much in maybe what you call a sick care system, but what are the other societal goods that we under-resource that also contribute to mental health? Schools, communities, et cetera, public spaces. And that's, again, the public health approach to mental health. So let's try to think about, we don't want everything to be paid for by insurance. There's other ways and strengths within communities that support mental health.
So I would like to thank all of you for sharing your wonderful golden nuggets and wisdom and lessons learned. This has been an awesome panel. So on behalf of the American Foundation for Suicide Prevention, we thank you. Then we also want to thank AFSP for sponsoring this health equity learning experience for all of us. I think we all have learned from each other, and we all have gleaned some things that we can use going forward in the future. Thank you all so much.
Thank you so much, Dr. Key, Dr. Swick, Dr. Barnes, and Dr. Chin, for such an informative discussion. I learned so much from each of you. Dr. Key, thank you for masterfully facilitating the discussion. Dr. Swick, I loved the way that you talked about a holistic approach, a public health approach to mental health and suicide prevention, which aligns with the way that we think about suicide prevention at AFSP. Dr. Barnes, thank you for stressing the importance of supporting communities. Again, one of the core values we share. And Dr. Chin, thank you for highlighting the importance of infusing culture into access and for sharing real-life examples such as the work of Lily Chin and UCA Waves, which is happening right here in my home state of North Carolina. Next, we'll be sharing a video greeting from U.S. Senator Reverend Raphael G. Warnock. Since 2005, Reverend Warnock has served as senior pastor of the Ebenezer Baptist Church in Atlanta, Georgia, the former pulpit of Reverend Dr. Martin Luther King Jr. Elected Georgia's first Black senator in 2021, Senator Reverend Warnock has carried his service and advocacy into the Senate, where he has helped pass legislation to create jobs, to address the maternal mortality crisis, and successfully championed efforts to cap insulin costs for seniors. Please enjoy these inspiring words from U.S. Senator Reverend Raphael G. Warnock.
Well, hello, American Foundation for Suicide Prevention. I'm United States Senator Reverend Raphael Warnock, and I want to start by welcoming you to the American Foundation for Suicide Prevention Summit. Your organization has a long, distinguished history of driving change through legislative advocacy, reducing barriers to accessing suicide prevention services, and expanding the availability of culturally relevant community resources. We know that suicide prevention is work that is vital to save countless lives. We must continue fighting to change the stigma around mental health and give it the same attention of care as we do our physical health, which is why my work to combat the mental health crisis in our country is something that I will continue to fight for right here in the United States Senate. Know that I understand the importance of this work and that you will always have a partner in me. Enjoy the conference, keep the faith, and keep looking up.
Thank you so much, U.S. Senator Reverend Raphael Warnock, for those encouraging, inspiring remarks. We certainly appreciate you. You know, one of the things we want to accomplish in these webinars is to showcase a community-based program, not simply to highlight the program, but to demonstrate that communities can create resources that serve their community members in suicide prevention. We will now be joined by Rosemary Suttle and Dr. Novaline Goklish, both members of the White Mountain Apache Tribe, who will present on today's feature program, the Celebrating Life Suicide Prevention Program. At the close of the presentation by Dr. Goklish and Ms. Suttle, we will engage in Q&A. Feel free to add questions to the chat. Also, as a reminder, there will be a survey link in the chat toward the end of the program. Please share your feedback. With that said, ladies and gentlemen, Ms. Rosemary Suttle and Dr. Novaline Goklish.
Thank you for your warm welcome. I hope each of you is having a peaceful and wonderful day. It is an honor for myself and Rose to be able to share about our suicide prevention program, our Celebrating Life Suicide Prevention Initiative that was established back in 2001. When you talk about suicide in our community, it's a very difficult topic. It's considered taboo. It's something that we were taught not to talk about, think about, invite into our space. But back in 2001, when our community experienced such a hard loss of young lives, our community had to stand up and go before our tribal leaders and stand before them and demand that something be done, that change take place. Our community needed to acknowledge that suicide was in our community and young people were taking their lives, and that our tribal leaders needed to address this. And so as our community members went before our tribal leaders with a heavy heart, they shared the devastation that they faced, the heartbreak, the heartache of losing a child, losing a loved one, and not being able to have questions answered as to why. And so the tribe took it upon itself, our tribal leaders, to establish a mandated suicide prevention program called Celebrating Life. Our tribe passed a resolution in 2002 mandating the reporting of suicidal behaviors. Through that mandate, our community members were provided with information on how to refer an individual who's struggling with suicidal behaviors. In 2006, an amendment was made to make the mandate reservation-wide. If you work on the Fort Apache Indian Reservation, if you live on the reservation, you are mandated to fill out a referral form on individuals who are struggling with suicidal behaviors, non-suicidal self-injury, and binge substance use, and refer them to our Celebrating Life Suicide Prevention Program. And through this mandate, as a program, we were also mandated to refer all individuals to our Apache Behavioral Health Services for individuals struggling with suicidal behaviors and the non-suicidal self-injury for those struggling with binge substance use who are 18 years of age and older. We were mandated to refer them to our Rainbow Treatment program as well. Our tribe took it upon itself to make sure that nobody falls through the cracks. If an individual presents at jail with suicidal behaviors, a referral was to be filled out on that individual so that they could receive additional services and support because they were struggling with suicidal behaviors. If somebody presents at school while they're at school with suicidal behaviors, the schools are also mandated to fill out the referrals along with the Indian Health Service. And so every department is a part of that mandate. that the tribe has established back in 2002 with additional amendments made in 2006. Through our suicide prevention program, we received a lot of training to be able to do the work that was asked of us by our tribal leaders, to go out and complete follow-up visits with individuals who are struggling with suicidal behaviors. Case managers were hired and trained, but at the end of the day, it's really hard to provide training on suicide prevention when we didn't really know what that would look like. The training that we received allowed us to use specific language when we were going to the home location of individuals we received a referral on. When you make contact with someone, these individuals don't know that a referral has been filled out on them. And so as you go to a home location, you introduce yourself. You let them know who you are, what program you work for, and why you're there. And it's important for the individual to know that you're there also because you care. You know, every single life matters. It's important for us to make sure that every referral that we receive, that we go out and make every effort to make contact with that community member who's struggling and remind them that they matter and that they're important to us and that we can help them connect with other resources and that we can continue case management with them if needed. And one of the important things that I would like to note is that at the heart of our work, it's our staff. It's our case managers. Our case managers make a difference every single day when they get in their project vehicles and they drive into the community and they go and make contact with somebody who's struggling. And for that person who is struggling, it might just be a simple conversation for that person to see that, yes, I want to live. It might just be a simple prayer that our staff are willing to do with them. And at the core of our role, it's just simply to show up, to remind our community members, especially in their darkest moments, that they are not alone, that we are here for them, and that we care, and that we are willing to listen to them without judgment. And together, we can make it through any storm. And our staff, they are the foundation of this program. When they go out and look for someone, there's times where they're driving over an hour for one individual. They make every effort to locate someone, to make sure that that person has received some type of a referral, some type of information about our program. It's important for our community members to know how important they are. Life is hard as it is, and our community went out on a limb. Our tribal leaders did as well, mandating something that other community members probably, wouldn't fully understand if it wasn't for those that have dealt with the hardship. It took a lot for our community members who experienced the loss to be able to go before our tribal leaders and share the importance of making a connection and letting people know that, in that moment that you're hurting, it's okay to hurt, but it's also important for us to be able to move forward with them. And so I'm going to turn this over to Rosemary Subtle so that she can share a little bit more about her case management work that she's been doing for almost 20 years.
So with the casework that I do, I go out in the morning, I get my forms together and I go out in the field and I go look for these individuals that I'll get their referrals on. There's times when I spent like 20 minutes with them. There's times when I spent like 45 minutes or an hour. As I'm talking to them, there's times when they tell me, it's not me, I didn't do that. And then as you're talking with them, doing the referral, later on, they're like, oh yeah, that was me. And my expression to them is I'm here to check on you, to let you know that you got a referral, and when they ask who reported on me, I'm like, it's someone that cares about you, that wants to know that you're getting the services that you might need. So as I go through the referral, I ask them about alcohol use in the past. I ask them about suicide attempts in the past. And I also ask about having thoughts of suicide. And so as I'm doing this, it's more like I'm getting to know this person a little bit. And as I just stand there and talk with them, they just keep opening up other events that have happened. Once we're done, once I finish follow-up, I try to get them the services they need. I'll either refer them to behavioral health or rainbow treatment. There's times when we do both behavioral health and rainbow treatment to make sure that we're getting the help they need. And also just letting them know that I can come back and check on them. If they need transportation, I'm able to take them to where they need to go to get the services they need. Most of the time, people just want to talk. They want to just express their feelings to someone that they don't even know. And with the kids, when I do follow up with the kids, we have, like Melvin stated, there's a mandate. I can go into the school without the parents' permission and meet the child and do a follow-up with them. And for me, it's easier to do a follow-up at the school and not at home, because when I do a follow-up at home, the parent is there listening to what the child has to say. Most of the time, when it's at home, the child won't share as much as they want to. So I just let them know, I'll come back and check on you. Would it be better at school? So when I go back and see them at the school, they talk a lot. They share a lot more. Throughout the day, I probably try to make like 8 contacts. When I come back to the office, I'll debrief with Noreen on what I do throughout the day and who I've seen. And for me, it's easier to do that. It's just letting her know the things I did, who I saw, who I had a hard time seeing. There's times when I have to travel out of area. They tell me he's here, but he lives here, but he's mobile. So he might be in a different area. So I go to that area, they tell me to go. When they tell me no, he was here yesterday, but maybe he's at that area. So it's kind of like being investigator sometimes and trying to find these people. I shared some of my days with you.
Thank you, Rose. So as I stated, I work with an incredible group of individuals. I have the pleasure of working with them every day. My staff, they are completely dedicated to their community members. They show up every day with not only professionalism and skill, but also with humor. Native Americans love humor. We love to laugh. We love to joke. They also show up with heart and a strong purpose to help. The staff that I work with, they are the spark of hope in our community. And it's important that we carry the load together. And through that, we also are reminded daily that without prayer, we wouldn't be able to continue to do the work that we're doing. It's important for us to pray as a team, to pray with our community members, to pray with our elders, in order for us to continue to move forward. The job that we have is not an easy job, working on suicide prevention. Working with individuals who struggle with life, wanting to live, whatever they're facing. We're not there to fix their problems. We don't have the means by that. But we're there to listen. We're there to try and connect with them. And for us, it's not just a job. It's a calling, a responsibility, and a blessing to be able to connect with our community members and to provide them with hope. When we were first working on our suicide prevention program, we struggled as a team. We presented to our tribal council, and they felt the heaviness of our presentation, and they asked, if we were doing okay as a staff. And we explained that, we were struggling working on suicide prevention, going out into the community. And it was important for us to be successful in making contact with our community members and not to let our community members down. But the heaviness of the topic was really getting to us. And so we were advised to create an elders council, invite elders to a meeting and share the work that you're doing and see if they would be willing to serve on an elders council to provide support, prayer, and guidance. And so we did that in 2007. And as we met with our elders, they were a little bit weary about the topic. But they continued to come to the Elders Council meetings that we held on a monthly basis. They offered support, they offered guidance, and they offered their prayers. And as we continued to work with them for about 2 years, they could feel the heaviness of the work that we were doing. And one day, in one of our meetings, they told us that they were going to facilitate the meeting for us. And when our elders, took over the meeting that day, they explained to us that they needed to talk to us about the work that we were doing, and they also wanted to talk to us about how we're raised in the community pertaining to suicide, and that we're raised with it being taboo. Our elders explained that the suicides that were happening in our community, it wasn't going to go away, and that we needed to continue to do the work that we were doing, and that they were there to support us, to guide us, and to pray with us. But they also wanted us to understand the importance of them giving us permission to talk about suicide. Not to feel comfortable talking about it, but to feel that we were given permission to talk about it. That was important, and that's what our elders did for us that day. As we continued to move forward as a team, we still struggled working on our suicide prevention program. This program is unique. It was developed within our community. And yes, it's housed within, Johns Hopkins University Center for Indigenous Health, but it's owned by our tribe. They're the ones that make the decisions on any modifications that are going to be made to this program. Is done by our Health Advisory Board and our Tribal Council. We do provide them with a lot of updates about our program, the progress that we're making, the struggles that we face, and the challenges that we deal with, the barriers that we come across on a regular basis. As a community, we have to continue to come together and find solutions in order for us to move forward. And it's important, for us to always acknowledge the families, that came before our tribal council. Those who had experienced the unimaginable loss of their children to suicide, they stood before our tribal council and they came with courage and they said, no more silence, no more stigma, no more preventable loss of life. And through that, we've been able to work on our suicide prevention program. We also work with our Elders Council, and our Elders Council, is developed through our suicide prevention program. But our elders wanted to do more. They wanted to give back. They wanted to be able to go into the schools and talk to our kids, talk to our youth. They wanted to reconnect with the youth. They felt that that was really important. And so I'm going to hand this back over to Rose so that she can share what our elders have done within our community, some of the outreach that they've done, and then some of the things that they've done in the classrooms as well. So, Rose.
So with the elders program, when we first started they wanted to put a curriculum together that they could teach in the school. So every night we take Brendan to the school and they talk about respect. Every month there's a different topic. It's respecting themselves, their teachers, and the students there, and also respecting their parents. And then also whether there's a topic where whether a female and a male join their roles as growing up, the things they need to know. So the elders do a lot in life. We as staff read the English portions to the kids, and the elders are the ones that are talking to the kids in our own native language. Then there's also words that they say that we tell them to take home to their family, which is written in Apache and in English. And we also have workbooks that we're working on, and the elders take roles in those workbooks also, where they talk to the youth that are in my program. They talk to them about not like living their life to their full potential, and if they have thoughts of suicide or made a suicide attempt, that there's a way to get past it, and there's a way to overcome it, and that suicide was never spoken of in the Apache lives. And they always encourage the youth, and they always encourage each and every one of us too, as a staff. They also let us know whenever we meet with them. Oh, I was wondering about you. I was praying to you guys. I was thinking then we're going to have a meeting again. So we do a lot of things with the elders. We also pick them out at times to go get a meal. And then if there's times when we're having a hard time, we even stop by to go see our elder and just spend some time with them, because they uplift us a lot. Without the elders, without celebrating life program, without nobody doing a lot of things for us with the elders, and I think the elders have a huge part of our lives. in this program also. Noreen's the one that got these elders together. When we first started this program, I remember the elders would get mad at us if we didn't speak our own language. During the meetings, me and Noreen would just sit down and look at each other. But slowly we've learned to what their needs are and what they want. But I enjoy working with the elders, so I'm going to hand it back over to you again.
Thank you, Rose. So through our Elders Council, we were able to develop a curriculum with our elders. It's called our Elders Resiliency Curriculum. And the elders, when they go into the classrooms, they like to share their personal experiences. They share their resiliency. And it's important for the youth to hear that there's always a way for them to move forward, even in times that seem like, they're not able to. And so our suicide prevention program started in 2002, and our case management started in between 2005 and 2006. And from there, we've been, in the community. We've had a strong presence for about 20 years. And I took over our suicide prevention initiative in 2006. And so I've been doing this for 19 years, working on suicide prevention. We do community outreach when we feel like we need to do a little bit more in the community. And so we'll set up little stations, we'll make sandwiches and we hand them out, and we talk to community members about suicide prevention, what resources are available, if they're concerned about anybody, if a referral needs to be made. If the person just wants to sit and talk, we have staff that will sit and talk with them. We also have hosted suicide prevention conferences, suicide prevention walks. We've done the candlelight walks as well. And our staff do the radio talk shows. They do a really wonderful job with that, along with our elders. We'll drive around in the community, and if we see people walking, we'll pull up beside them, talk with them, and give them some refreshments, and just let them know, that we're here, even if they just need to talk. It doesn't have to be about suicide, but if somebody is struggling, we want to make sure that they know that there's additional support for them. When somebody is needing transportation, we do provide transportation for our community members as well, because we reside in the rural, area in Arizona. And so, transportation is difficult for some people to get to certain places, and, a few miles apart from one department to the next, sometimes for some of them, depending on what they're needing to do. And so we do offer that as well. And through our Celebrating Life program, my staff are not counselors. We don't provide counseling sessions. We provide a safe space for our community members to connect with someone who is willing to listen, show compassion, and share resources. We provide case management continuously for individuals who request it. Or if the staff feel like I need to go back and meet with this individual, I want to, continue to do case management with them. It's important that I continue that role with them. And so it's important for us to be able to offer these services. And we're fortunate and grateful that our tribal leaders support the program, that we've established with them, in the partnership that we have. And so I don't know how much time we have left, and I think we've probably explained a little bit more about our program, so I'll go ahead and stop here and see if you have anything else for us.
Well, first, just let me say to both of you, Rosemarie and Dr. Gokless, thank you so much for being willing to come on and talk about your program. I will tell you, I am just blown away listening to what you've built here. And I know to you, it probably feels, because you're in this every day, it feels probably much more routine to you. But to me, hearing about it, It's just a remarkable program. I want to start though with just acknowledging the name of the program, Celebrating Life, Suicide Prevention. I love the fact that you entitled it Celebrating Life. And I have to ask, was there intentionality about calling it Celebrating Life? Because you're automatically, as I listen to that, you're automatically shifting the conversation and focusing on, celebrating the fact that a community member lived and was a part of your community, as opposed to only focusing on the suicide. So was there intentionality in calling it Celebrating Life Suicide Prevention Program?
Yes, when discussions were being had about what the name of the program would be, there was individuals that were brought together to identify, what should we call this program? It's going to be really important that we focus on a name that is going to reflect the work that we're doing. Mm-hmm. And so as meetings were being held about, what the name of this program was going to be, we had some of our grassroots leaders and our elders that were also at the table that shared the importance of, celebrating our life every day. Mm-hmm.
Yeah.
When you're going out there, you're celebrating that person that's been struggling, and you're letting them know that they matter and that they care and that they're important and that they're a part of our community and that we do care about them. And so that's how it was established with individuals that were sitting at the table when they identified the name of our program. And when that took place, Rose and I were not a part of that at that time. We were working in different areas.
Yeah, one of the things I love about that title too is I think that oftentimes when we talk about suicide and suicide prevention, we really only focus on the individual that we've lost to suicide or the individual that's attempted suicide. And we forget that an entire community is impacted by their suicide loss, and their families and friends and co-workers that are also experiencing that loss. And so when you celebrate life, you're also acknowledging that there's a whole community that is still here and is coming together and rallying around each other to support the people that have experienced that loss. So again, I applaud the name. I also am curious. I know that you mentioned there was loss of life in 2001, and that you were at a point as a community where you felt a need to come together and and address the loss of suicide, the loss of life to suicide. So I'm curious, was there something special about 2001? Because it seems like that was a bit of a tipping point. What was it about 2001 that allowed the community to come together and say, now is the time to do this?
So in 2001, in a 6-month period, there was 11 deaths by suicide. And 8 of them were our young people, our youth. It's their family members that convened and decided that they were going to attend one of the tribal council meetings and share their feelings, their grief, the loss of life and the impact that it had on them, and that they wanted a program developed that would support community members who were struggling and connect them to services before it was too late, and also to identify a program for community members who were going through this so they weren't going to go through it alone. Mm-hmm. So there would be people from the community that would support them and be there for them. And so that's what our community members requested, and that meetings take place with departments so departments understand and see the importance of, working together to address a very difficult topic and to provide support and services for those in need, but to do it as a unified front.
Mm-hmm. Yeah, and you mentioned too how much of a taboo subject just talking about suicide is, and that's one of the reasons it's all the more impressive to me, too, that you were able to get the involvement of elders, because I know in a lot of communities, that tends to be where there's kind of a generational gap, that oftentimes the younger generation is more open to talking about suicide and mental health. And we often find that the older people in the community, who are often community leaders, often are the ones who are the most hesitant about talking about suicide and embracing it as a conversation. In your case, you were able to get buy-in from the elders and have even gotten to the point where they're actually involved in the program and talking with community members and young people in particular. So I'd love to hear what that process was like, because I know those elders didn't just see this and say, oh, this is great, we're absolutely happy to join in. And you talked a little bit about it taking some time. What do you think it was, though, that got the elders to the point where they became supportive and even participatory as far as the program is concerned?
So we had our first meeting with our elders in April of 2007. We sent out 25 letters of invite to specific elders that were identified by our tribal leaders, indicating that these individuals would support the effort, the initiative, the suicide prevention initiative. Mm-hmm. And so we had our first meeting, and in the meeting, we presented our Celebrating Life program that was in place in partnership with the tribe and the Indian Health Service. And we explained to our elders that this is our suicide prevention program. This is our Celebrating Life program. This is what we do. We get referrals from the community, and then we go out and make contact with individuals who are struggling with suicidal behaviors. But as a staff, we're struggling with this. We're having a really hard time. It's difficult for us, and it's really heavy. And so that's why we, wanted to create an elders council, and we're hoping that you'll continue to attend and participate in the meetings and, help us and support us and guide us through this effort. And we had 20 of the elders that agreed and remained, and 5 said that they would not be able to do this for personal reasons. And so they excused themselves before the meeting was over. But the 20 elders that remained, they explained their reasons for staying. And also for some of the elders, they felt that it was important for them to support us. And so at the beginning, we worked with our elders, and it was just meetings, monthly meetings. Sometimes, we would have a meeting twice a month and share a meal with them. And then we would just explain the work that we were doing, some of the difficulties we faced, going to someone's house and talking with them. And this is what they shared. And it was really hard, and what we focused on. And when, about 2 years after we started our elders council, the oldest elder that was attending our meeting at the time shared that, it's important for us to facilitate this meeting for you guys today. We're going to be the one in charge of the meeting. It's important for us to speak and share our thoughts. And so we gave them the floor. We were told to sit down. We're raised in a community where you respect your elders. When your elder tells you to sit down, you're going to sit down. When an elder is speaking, you don't talk, and you are not allowed to interrupt our elders. And so we sat there, and our elders took over our meeting, and they opened with the prayer, a very strong prayer. And when they took over the meeting, the purpose of that meeting and the purpose of them explaining and talking to us was to remind us that we needed to focus on the life side of our job. Yes, you are dealing with individuals who are struggling with suicidal behaviors, but they are still here.
Yes.
They might have made a suicide attempt, but they are still here. They might have strong thoughts about not wanting to live, but they are still here. You are able to connect with them, talk to them, and identify resources for them. So you need to focus on the life side of your job. The reason why your job is so heavy is because you've taken the word suicide and the death side of it and carried that. That's what you're carrying, and we need you to release that. And when you meet with someone and they are sharing their struggles and their burdens and their hardship, you listen to them. And when you leave their house, you are leaving with some of that heaviness. But once you get in your vehicle, you leave it there. It has nothing to do with you. It is not your burden to carry, because you are going to be going to the next person's house and you're going to be talking with them. That heaviness that you carry, sometimes you hand that off to someone else. So your job is to learn how to release things before you get to the next home location. You need to be able to connect with people on a positive note, is what was explained to us by our elders. And that meeting had so much meaning for us. It helped us to see what it means to work on suicide prevention from a positive perspective. And that was important, and that's the role that our elders played, and they still play that same role for us today.
Thank you for that. You have woven into your program here so many just vital pieces of it, I think, including a big piece of it being social connection. You've clearly built in social connection, both in the way that you bring the elders in and have them connecting with community members, the way that you've built in even stopping to check and visit with people who you feel like may need that. And that is so important. But you've also built in, as I'm just hearing you talk about some of the advice from your elders, you've also built in self-care for those who are providing help to folks in the community, because you're clearly conscious of the fact this can be heavy work. So you're also, it sounds like, aware that the helpers also need an outlet and also need a way to refresh and take care of themselves.
Yes.
I do. Go ahead. I'm sorry.
Oh, I was just going to say, I was going to have Rose speak to that if you were finished. Sorry about that.
Yeah, by all means, please, Rose.
With self-care, I do that a lot. And before, when I first started, I had a hard time releasing things, releasing what the person was struggling with. What the elders told, learned that from the elders, that we need a way to release things. So now, I've learned how to do that. I've learned how to let things go. And then I also, with self-care, I do so much. I either, when I'm feeling like a little bit stressed, I tend to do a lot of crocheting. I do a lot of beadwork. I also do a lot of reading. Sometimes I just go for a ride. And with Melville, she started a program where we learned how to bead. So now I really enjoy beading. And we also go to the schools, and we also have dorm. We do crocheting, we do beading, and we also do painting with the plates of the dorm. That's still in the dorm. So, but we do a lot with self-care. There's times when it gets heavy, Noveline brings either a pastor or a medicine man in, and we get prayers done here at our office also.
So you've mentioned prayers a couple of times, and so is faith also a core component of your program?
Yes.
And you also, Rose, as you were talking earlier, and you mentioned that when you connect with people, that oftentimes when you first have the conversation, they start with, no, it's not me. I was not the one that wanted help. And then they eventually come around to, yes, it was me. What I'm curious about, though, is what happens in between, because clearly there's something in the way that you are connecting with them that allows them to relax, allows them to open up, and allows them to say, yes, I was the one that was here for help. What is it, do you think, this allows you to create that connection with them, to where somebody may start off not wanting to admit that they need help? Because that's something that's so hard oftentimes to get people to transition from that point of not acknowledging they need help to the point where they are willing to acknowledge they need help. What's happening in that conversation with them that allows them to move from that place of not trusting you to trusting you to provide help for them?
I think it's going through the referral form. As you're doing the follow-up, you ask so many questions, and then just being open with them and being able to have them trust you. And it's the questions that you ask them. So in the past, have you made a suicide attempt? Mm-hmm. And then there's also one that says, in the past, have you ever thought of suicide? And so at most time, there's a few times when I get to there, they're like, yeah, I've told you that it wasn't me, but it was you. So then we go back to the beginning and we go through the issues that the person was going through at that time.
Yeah.
And what caused them to have those thoughts on the down attempt.
Yeah.
And then helping them connect with services.
I would still venture that there's something in that conversation, because I get that there are questions that are being asked of them, but there's a difference in being asked questions in a very mechanical way and being asked questions in a way that feels like you genuinely care. And so I suspect that people sense the caring in that connection, in that relationship. Now, when you're having or providing these services within your program, you are clearly able to craft the way that you interact with them, the things that are important. You're able to mirror those things that are important in your community, and you're able to build this around things that are already strengths for your community. Do you have situations, though, where you're having to refer people out, that once you've seen them, you have to refer them outside the community? What does that look like?
It's times when they have bad experience with behavioral health, or bad experience with different facility. So we also offer program services of the resolution. Mm-hmm. And so if they want that services, then we'll drive them to the facility.
Yeah, I love that you have addressed so many things other than just that presenting mental health challenge or emotional or whatever challenge they're faced with, because you mentioned also that if they need medical care, you also refer them for medical care. You can provide transportation if that's needed. You talked about providing meals sometimes for people who don't have food. So you're addressing so many of those social drivers that can impact our mental well-being, but also can impact us feeling like we're part of a community and a part of a society. So that seems to be a really big component of it, is addressing the whole person. Is that something that has been a part of the program from the beginning, or those things that you were able to add on as the program grew? And I submit that question to either of you.
So the program addressing an individual holistically has always been a part of our Celebrating Life program. And even, as staff, we know it's important that, you're being taken care of completely, not just your physical body when you meet with a provider, but your mental health as well. And so when somebody has gone to the hospital and they meet with a medical provider, those, whatever issues they have, that's being addressed there. And sometimes whatever information they've been given back, they feel like, my life isn't the same anymore. I don't know if I want to live anymore. Life is just difficult. I have all these health problems. And that's where we come in with our, traditional healers, our church leaders, the pastors. They can go and provide prayers for them, also continue a relationship with them, a spiritual journey with them. So it's really up to the individual and how they feel and in which direction, they really want to take this. And so I wanted to add a little bit more to our suicide prevention program. When we first started working for this program, well, specifically for me, I know that from the time I started working on it until now, I know it's really changed me in a lot of ways. It's made me stronger in ways that I couldn't have imagined. And I know for my staff, it teaches you things and you see things that other people aren't aware of because of the people we come into contact with. But our Celebrating Life program, we've learned a lot from this program. And some of the things that we learned is that healing led by a community and that, that is grounded in culture is not just possible, but it's powerful. Indigenous knowledge is not a relic of the past. It's a roadmap to the future. From the beginning, as a staff, we were discouraged by other professionals in and outside of our community. We were told that we didn't have the qualifications to do the work that we were doing. It was disheartening to hear these negative comments, especially from professionals within our own community. But in the end, we continued to move forward with our Celebrating Life program, regardless of what was shared. And I also want to share, some examples. We can make a positive difference in our own community. Our community-based approach has yielded remarkable results. A 30% decrease in suicide deaths and a 53% decrease in suicide attempts in our first 12 years. Since then, our recent rigorous study, a randomized controlled trial for youth suicide prevention, the first of its kind in the world, demonstrated that participants in our intervention had a 95% relative reduction in risk of death by suicide and a 57% reduction in suicide attempts compared to matched controls within our community. Our case management is a vital part of our Celebrating Life program. You heard from Rose the work that she does when she goes into the community. Her dedication, being able to connect with someone, being able to talk with a community member and connect with an individual that you've never met, you've never had a conversation with, but you're able to engage them, talk with them, and help them understand that there's hope for them. That makes a big difference. And when we engage with a community member, they become our priority. Mm-hmm. We center them in our work, ensuring that, they feel truly heard and seen. And that's what my staff do every day. They go out and they build relationships. And they go out and they continue to connect with these community members, our community members who are faced with, some of the life's challenges. Mm-hmm. They live in situations that we couldn't even imagine.
Yeah.
And they're surviving. And we want them to understand and to see that, they can live and that they can also enjoy life. And we do have, positive stories, from community members who have attempted suicide, struggled with substance use. We've worked with them, supported them for more than a few years, and they come back and they'll share, that I'm doing really good. I have a job, I got my kids back, I have a house, I have a vehicle, I'm living life. And, they'll come and they'll tell Rose, thank you for being there. Thank you for everything that, you did for me during my hardest times. I mean, that's Rose's reward. That's the reward that we work for every day. So thank you.
Thank you. Fantastic. One of the questions I'd like to ask programs is, for any funders or philanthropists that may be in the audience listening, why should they invest in your program? I think you answered that just by the impact that you're having. You have the data that demonstrates that you're making a difference in your community. Is there anything that you would add as to why a program like yours is one that anyone who's looking to invest in life-saving work would be interested in your program? Is there anything you'd add to anything you shared already?
I think that, our program is unique. It was developed within our own community.
Mm-hmm.
And we do have curriculum that we've also developed and that we offer that as a service to our community members. And it focuses on coping skills. So any finances that we receive, any funding that we receive to further support the work that we're doing, that work would allow us to continue to connect with our community members and continue to provide case management. It'll help us to connect with our community members and continue to offer them hope when it just feels like there's nothing there for them. We're also doing, coping skills, teaching them different ways of coping skills. Rose mentioned that we offer beading. We put together beading kits. We sit there and we teach them how to bead. They sit there and they teach them how to crochet. They sit there and they paint with them. These are important outlets that community members are learning, and then they can also rely on that. If they're interested in being an entrepreneur, these are also avenues that they can take, and then they can develop their skills with that and, just improve upon their own lives, and be better for it, by working with us. And, this is one program that we had. There are other programs in our community that offer a lot as well, but, thank you for allowing us to, share about our Celebrating Life Suicide Prevention program and be able to just explain the important work that we do here in our small community. So thank you.
Thank you so much for being willing to come on and talk about your program. One of the things that we try to highlight with these webinars, and in fact, the entire purpose behind the Upright really is to demonstrate that given the opportunity, communities can create programs that are culturally relevant, that are relatable to the lived experience of the community that they're serving, and they're best positioned to do that because they understand the community. It's a community that they live, work, play, and worship in. Your program epitomizes that, so thank you so much for being willing to share that today. As we come to the close of today's webinar, I want to thank all of our presenters, Dr. Swick, Dr. Barnes, Dr. Chen, Dr. Key, Dr. Goklish, and Ms. Suttle for being with us today. And thank you, U.S. Representative Reverend Raphael Warnock, for sharing such encouraging and powerful remarks. And thank you to our interpreters for being with us today. And thank you to our audience for joining. Your feedback is very important to us, so please take a moment to fill out the survey. As a reminder, if you would like to learn more about the American Foundation for Suicide Prevention, please visit our website at afsp.org. You can also learn more about the Upright at afsp.org/theupright. And remember, if you or someone you know is living with mental health challenges, get support. And if you or someone you know is in crisis, you can call 988 to be connected to a trained counselor who can connect you with the help, with the services, with the support you need when you need it most, because you matter. Your life matters. Your pain matters. You are not alone. And we want you to be here tomorrow and every day after that. Thank you, and enjoy the rest of your day.